Welcome to the module Scale and Spread of Health Interventions. First, let's meet our experts. Dr. Catherine Fisher, School of Nursing, McMaster University. Dr. Jenny Plow, School of Nursing, McMaster University. Dr. Larkin Lamarche, Department of Family Medicine, McMaster University. By the end of this module, you will understand the concepts of scale-up, spread, and sustainability, assessing scalability and developing a scale-up plan, and how to implement a scale-up plan. We will provide 2 real-world examples of studies that involved scale-up planning and implementation to demonstrate scale-up and spread of health interventions. When it comes to moving healthcare practices forward efficiently, Canada is a country of perpetual pilot projects. We seldom move proven projects into stable, funded programs. Funding streams have launched thousands of pilot projects across the country, projects that usually die when their initial funding runs out, regardless of their merit. That statement was made in 2009 by the Honorable Monique Béjean, former Federal Minister of Health. Her statement is as true today as it was in 2009. What Madame Béjean was referring to is known as the Valley of Death. This figure shows the 2 common death valleys in the Canadian healthcare system. Valley 1 depicts the limited ability to translate information from basic research to research in a clinical setting. Valley 2 depicts the challenge of integrating clinical research results into clinical practice and healthcare delivery. It is critical to bridge these gaps between research and clinical practice to ensure that researchers' time and talent in developing and testing interventions is not wasted, and that broader societal benefits are realized from programs that show promise. The purpose of this module is to provide researchers with the tools to successfully plan and scale up effective healthcare programs and avoid the death valleys so common in our healthcare system. Before we begin, we should clarify that we use the terms interventions, innovations, and programs interchangeably to mean provider-led activities with the purpose to assess, improve, maintain, promote, or modify the health of a client population. Let's begin by defining what we mean by scale-up. According to the World Health Organization, scaling up in the healthcare sector is defined as deliberate efforts to increase the impact of health service innovations successfully tested in pilot or experimental projects so as to benefit more people and to foster policy and program development on a lasting basis. Now, let's first introduce 2 examples to provide some context for thinking about scale-up. We will begin by describing 2 different studies involving older adults that have included scale-up planning and implementation. At the end of the module, we will revisit these 2 studies and describe some of the strategies used and lessons learned in scale-up.
The first example is the Aging, Community, and Health Research Unit Community Partnership Program. You can find out more information about this program on this website. The goal of this program is to promote self-management for older adults who have diabetes and multiple chronic conditions. This program involves a partnership between primary care settings and community partner sites such as the YMCA. The core components of this 6-month program include home visits by nurses or dietitians, a monthly group wellness session at a community partner site, a monthly case conference of the intervention team, and nurse-led system navigation. Underlying concepts of the intervention core components include the following: self-efficacy, holistic care, social determinants of health, caregiver engagement and support, person-centered care, transitional care, multimorbidity, self-management, and health promotion and safety. This program was co-developed in partnership with older adults living with diabetes, healthcare providers, and researchers. The program has been tested in a number of communities in Ontario and Alberta and shown to be effective. We are currently conducting a pragmatic, randomized control trial of this program in Ontario, Quebec, and Prince Edward Island, in which we're planning for scale-up from the very beginning. Our aim is to deliver provincial scale-up plans for each province.
The second example is Health Tapestry, which stands for Health Teams Advancing Patient Experience, Strengthening Quality. You can find out more information about this program on this website. The aim of Health Tapestry is to help people stay healthier for longer in the places where they live. It does this through 4 interconnected parts: trained community volunteers, the interprofessional healthcare team, and links to community resources, all supported by technology. So how does Health Tapestry look in practice? Meet Janina. She is 75 years old and lives with her partner Sam. She joined Health Tapestry after it was recommended by her family doctor. Health Tapestry starts with a pair of trained community volunteers who visit Janina at home and get to know her. The volunteers learn she has 4 children and 3 grandchildren. She enjoys spending time with her family and friends and volunteers at her church. The volunteers ask questions about her life, health goals, and health needs and record the answers on the TAP app. Janina's answers are summarized on a report, a TAP report, and electronically sent to her healthcare team. Janina's report indicates that her goal is to improve her physical strength, maintain her independence at home, and that she has fallen in the past year. An interprofessional healthcare team called the TAP Huddle reviews the report to create a care plan. The healthcare team and volunteers work with Janina to follow the care plan. Janina meets with members of her care team at the clinic and in her home. The volunteers visit Janina again to help her arrange transportation for her to attend exercise classes at the senior center. With the care plan in place, Janina is supported reaching her goals and is better connected with supports in her community and her healthcare team. Keeping these examples in mind, let's learn more about the ScaleUp process.
It is helpful to recognize and situate the related concepts of spread and sustainability within the context of ScaleUp. Spread and ScaleUp are both generally understood as meaning to extend something more broadly. As a result, the terms are often used interchangeably in the implementation science field. We too use the terms spread and ScaleUp interchangeably to capture efforts that extend an intervention to widespread geographical boundaries not limited to one or multiple sites of a clinic, facility, or organization. Sustainability refers to maintaining adopted or scaled out interventions over time to secure lasting population impact. Successful scale-up plans include deliberate procedures to ensure sustainability, such as integrating the intervention in policies, practices, budgets, and other dimensions of the healthcare system. Before discussing the details of planning and executing scale-up, it is helpful to think about what is involved so we can better understand why scaling up interventions is so complex and challenging. We can think of scaling up as involving changes to inputs, like mobilizing more funds or hiring more staff. Outputs, like providing more services, better access, better quality, or more efficiency. Outcomes, like reaching more people or increasing uptake, or impact, which might include reducing disease conditions or mortality. Successful scale-up of health interventions typically involves changes to all of these elements. Changes to inputs, outputs, and outcomes are required in order to see an impact at the population health level. It is particularly important to recognize that changes to inputs alone are not enough for successful scale-up. The reason inputs are insufficient is that resources alone cannot guard against the implementation fallacy, which is the assumption that good interventions are self-replicating and spontaneously adopted. Robust evidence shows that scale-up of effective interventions requires careful planning, organization, and execution, and requires work on several fronts at once, including a partnership of organizations working on service delivery, financing, policy, and coordination, commitment from a core group of people to maintain momentum, and monitoring the implementation of scale-up plans. When we reflect on the work involved, we can see why it is important to start planning for scale-up early on. Some people consider it premature, putting the cart before the horse, to plan for scale-up before the evidence is available that shows that the intervention worked. Others disagree. Many experts claim that waiting until we have definitive evidence that an intervention is effective before starting to plan for scale-up is too late. It takes time to build the relationships that enable organizations to partner together to implement scale-up. Much of the work that goes into planning and executing a research study to determine whether an intervention works jumpstarts the changes required for successful scale-up. Policy and system changes are often required before an intervention can be introduced in different settings, and these do not happen overnight. It can take many years to acquire capacity in terms of infrastructure, funding, and champions to support ScaleUp and maintain the momentum. In general, experts agree that we should begin early by designing an intervention with the end, ScaleUp, in mind. This means incorporating ScaleUp planning into the design of the research study that will test an intervention. This way, you will not reach the end of the study without having the necessary information, support, and plan in place to take effective interventions to the next level and roll them out as stable, funded programs to benefit the broader population. Pragmatic research studies support the notion of beginning with the end in mind. Pragmatic studies include real-world elements, such as delivery of the intervention by providers in the practice setting where scale-up will eventually occur, and using outcomes preferred by patients to measure the impact of the intervention. So, how do we design a research study with scale-up in mind? What does this really mean? It means that we design the study to engage stakeholders early on and capture information needed to support decision-making that will occur during the planning and execution of ScaleUp. To know who to engage and what information to collect, we need to better understand the ScaleUp process itself. Various organizations have offered frameworks and guides for scaling up interventions, but few practical tools exist. We present one guide that was developed by the Ministry of Health of New South Wales in Australia that is widely used and relevant to the Canadian healthcare context. The guide was informed by a systematic literature review, as well as a Delphi process involving senior policymakers, practitioners, and researchers who were participating in scale-up activities in developed countries. They describe 4 steps of scale-up. Step 1, assessing scalability. Step 2, developing the scale-up plan. Step 3, preparing for scale-up. And step 4, scaling up the intervention. Let's look at each of these steps in more detail to understand the activities being done and the information required to complete them. Step 1, assessing scalability. Scalability is defined as the ability of a health intervention shown to be efficacious on a small scale or under controlled conditions to be expanded under real-world conditions to reach a greater proportion of the eligible population while retaining effectiveness. We can think of scalability as the prerequisite for scale-up. Assessing scalability involves many considerations that collectively determine the potential for scaling up an intervention, with high potential interventions moving forward to step 2, where a scale-up plan is developed. Key considerations in assessing scalability include evidence of the effectiveness of the intervention, alignment with the strategic context, which considers the consistency with policy directions, acceptability and feasibility of the intervention, including resource requirements and barriers and facilitators to implementation, and potential reach and adoption, including the uptake of the intervention by the target populations and organizations delivering it. Previous clinical trials and pilot studies are good sources of information on an intervention's effectiveness, as well as its acceptability, feasibility, and adoption. However, whether other studies adequately inform the assessment of scalability depends on how they were designed in terms of stakeholder involvement, evaluation of implementation, and intervention fidelity, consideration of resource requirements, diversity of test sites, and inclusion of pragmatic features. This relates to our earlier point about designing an intervention with the end, scale-up, in mind. The same is true for the studies that evaluate the intervention. They too need to be designed to capture the broad range of information that will be needed to assess scalability. The World Health Organization guidance document, beginning with the end in mind, offers 12 recommendations on designing studies with scale-up in mind. We briefly review the recommendations to highlight the key features that need to be considered in designing intervention studies in order to inform scalability assessment and enhance the large-scale impact of the intervention. The 12 World Health Organization recommendations fall into 3 main groups of activities. The first group is intervention design, which includes tailoring the intervention to the sociocultural and institutional settings where scale-up will occur, and keeping the intervention as simple as possible to facilitate scale-up and enhance fidelity. The second group, intervention testing, includes testing the intervention across the diversity of settings where scale-up will occur, testing the intervention in real-world pragmatic settings, assessing the implementation process, and determining the adequacy of evidence needed to decide on scale-up. The third group, knowledge translation and exchange, includes engaging stakeholders in a participatory process, establishing the relevance of the intervention to providers, patients, and policymakers, developing consensus on expectations for ScaleUp, advocating for funding for ScaleUp, advocating for necessary policy and system changes needed for ScaleUp, and planning for dissemination of information about the intervention and its impacts. Evidence shows that designing these activities into intervention studies provides the breadth of information needed to assess scalability and enhances the potential for ScaleUp. Experts acknowledge that one of the most difficult issues in assessing scalability is determining when sufficient evidence has been obtained to make a decision on ScaleUp. The decisions around ScaleUp are not unfamiliar to researchers, who often encounter the need to make decisions under conditions of uncertainty. It will rarely be the case that all the information is available to assess scalability at the time of the assessment. It is neither possible nor cost-effective to study all populations and organizational settings. Thus, uncertainties will often remain about issues like how the intervention can be adapted to fit different contexts, what the effect sizes will be, and possible population impacts. Judgment will be required about how important the information gaps are, whether they can be addressed during implementation, or whether more research is required before deciding on ScaleUp. Step 2. Developing the ScaleUp Plan. Step 2 involves developing the ScaleUp Plan for high potential interventions identified in Step 1. The ultimate goal is to have a clear, concise plan for ScaleUp that includes an overview of how this will happen and what ScaleUp will look like if successfully completed. Key activities involved in developing the ScaleUp Plan include describing the intervention. It is important to describe what the intervention looks like in the settings where ScaleUp will occur and clearly distinguish core versus flexible components. Completing a contextual analysis to map the social, political, and organizational environments where ScaleUp will occur, which will in turn flag barriers and facilitators of ScaleUp. Determining who will be involved to support ScaleUp and the nature of their involvement. ScaleUp will likely involve a team of individuals who may come from organizations involved in testing the intervention or new organizations established to support ScaleUp. Determining human, technical, and financial resource requirements for ScaleUp. This includes the costs of the organization or team that supports ScaleUp, as well as the costs of activities relating to monitoring and evaluating ScaleUp efforts. Selecting the approach to ScaleUp. There are two main approaches, horizontal and vertical. A horizontal approach includes introducing the intervention to sites or groups in a phased manner. A vertical approach involves introducing the intervention simultaneously across a whole system. The World Health Organization notes that successful ScaleUp requires a combination of both approaches. For example, ScaleUp often starts with organizations which are poised to implement the intervention due to capacity, strong leadership, or other organizational assets. These initial organizations then serve as models to build momentum for further ScaleUp. Writing the ScaleUp Plan. There are some particularly useful tools for helping to develop a ScaleUp plan, such as the Consolidated Framework for Implementation Research, CFIR, and Normalization Process Theory, NPT. CFIR assists with evaluating barriers and facilitators relating to intervention characteristics, outer and inner practice settings, characteristics of individuals, and the implementation process. Examples of constructs include the relative advantage of the program, which are intervention characteristics, patient needs and resources, which are outer setting characteristics, networks and communications in the facility, inner setting characteristics, and knowledge and beliefs of stakeholders, characteristics of individuals, and engaging stakeholders in the process, implementation process. NPT is an action theory that addresses what individuals do to embed a new intervention in practice. It includes the four constructs of coherence, cognitive participation, collective action, and reflexive monitoring. NOMAD, which stands for Normalization Measure Development, is an instrument used to assess the four NPT constructs. Our examples at the end will demonstrate how we have used these tools in ScaleUp. The end result of Step 2 is the ScaleUp Plan. While the activities leading up to the ScaleUp Plan seem relatively clear, questions remain on what the ScaleUp Plan should look like, what format it should take, and how detailed it should be. Currently, there are very few published ScaleUp plans. However, there are some helpful resources that can serve as a guide to writing up the plan. For example, the Institute for Healthcare Improvement, and Health Quality Ontario, now part of Ontario Health, both offer publicly available, free of charge spread planners that provide guidance on how to develop a spread plan. One important difference between a spread planner and ScaleUp Plan relates to a point made early on in the module. Compared to ScaleUp, spread can refer to implementation efforts that are more limited in scope and apply within the boundaries of an organization. This reflects the origins of spread planners, which were developed to facilitate quality improvement initiatives within an organization. The implication of using spread planners for broader scale-up initiatives is that they may need to be adapted to reflect the interests and features of multiple stakeholders and settings where scale-up will occur. Currently, there is very little evidence on the effectiveness of spread planners, so we don't know the factors underlying their effectiveness or the methods needed to successfully implement them. This means that we are entering uncharted territory when it comes to knowing what constitutes an effective, successful end product, the ScaleUp Plan. Given this situation, we recommend involving stakeholders early and often in developing the plan. Context is key, including the nature of the intervention, the organizations and settings involved in ScaleUp, and the target population for which uptake of the intervention is critical to achieve impact. Regular consultation with stakeholders can help to establish consensus on the content and level of detail for the ScaleUp Plan to ensure that the end product meets stakeholder expectations and adequately informs implementation efforts. Recognizing the evolving nature of planning also helps. ScaleUp plans, like all plans, are dynamic and need to be updated to remain relevant and responsive to the learning from implementation efforts and changes that occur as ScaleUp unfolds. Step 3. Preparing for ScaleUp. Preparing for ScaleUp involves performing a reality check to ensure that the ScaleUp plan is acceptable and that sufficient support and resources are in place to implement the plan. It builds on clear communication strategies and relationships already formed with stakeholders to secure the commitment and support of decision makers and mobilize the resources required by the organizations that will deliver the intervention. Step 4. Scaling up the intervention. Scaling up the intervention means implementing the ScaleUp Plan. It is important to emphasize that the plan is just that, a plan. As ScaleUp unfolds, adjustments will become necessary as organizations adapt to the cultural and structural changes needed to make delivering the intervention part of routine practice. Data collection systems will need to be developed for the ongoing capture of key ScaleUp data, including REACH, which captures uptake by the target population and acceptability of the intervention. Effectiveness, which refers to the impacts to population health, services, and costs. Adoption, which is the uptake by delivery organizations, staff, and settings. Implementation, which includes intervention fidelity and adaptations to the intervention. And maintenance, which refers to sustaining the intervention over time. You may recognize the highlighted letters above, which spell REAIM. REAIM is a framework to help plan programs by encouraging program planners, evaluators, researchers, and policymakers to pay more attention to the essential program features that can improve the adoption and implementation of effective, generalizable, evidence-based interventions. REAIM has been used to translate research into practice in order to improve the chances of programs working in real-world settings. This goal is consistent with the overall goal of ScaleUp. As such, REAIM serves as a strong foundation for the development of performance measures that can be used to judge ScaleUp progress and identify areas where improvements are needed.
We are now going to discuss the strategies and lessons learned in scaling up for the two studies that we described at the beginning of the module. First, in the Aging Community and Health Research Unit Community Partnership Program, we are actively planning for ScaleUp. We have very strong evidence of the acceptability, feasibility, and effectiveness of the Community Partnership Program. We started with a workshop where we engaged public research partners as well as decision makers and providers in discussion of possible approaches to address the challenges experienced by older adults living with diabetes and multiple chronic conditions. The Community Partnership Program was co-designed in collaboration with older adults with diabetes and primary care and community care providers. The program was pilot tested in one site and found to be feasible and acceptable. We then conducted a pragmatic randomized control trial in multiple sites in Ontario and Alberta, demonstrating the potential positive impacts of the program. Currently, we're conducting a pragmatic randomized control trial in diverse settings in Ontario, Quebec, and Prince Edward Island to further assess the effectiveness of the program and plan for scale-up. The Community Partnership Program has strong alignment with the provincial policy direction. The current project was developed with careful consideration of the provincial policy priorities, including areas such as chronic disease management, high users of the healthcare system, and older adults. We have established a governance structure that facilitates the active participation of patient and public research partners, policy decision makers, and healthcare providers throughout the research process that will support scale-up planning. For example, the steering committee includes patient and public research partners, policy decision makers, and researchers from participating provinces that meets regularly to discuss scaling up opportunities for the program and lessons learned. In each of the communities where the trial is running, we have a community advisory board composed of local patient and caregiver partners, healthcare providers, and decision makers who meet regularly to discuss study progress and scale-up planning. To promote feasibility of the intervention, we have developed online training modules for intervention teams on the key components of the program. These modules include information on topics such as self-management and multimorbidity. The training modules will facilitate scaling up of the program in other teams and communities. Recognizing that it's very important to understand the context of healthcare in scale-up planning, we are tracking the adaptations that we are making in each community and province to ensure that the program will work. For example, in Quebec, because of the scarcity of dietitians as part of primary care teams, we are involving community nutritionists as part of the intervention teams. We are closely monitoring the implementation of the program in each setting. We are using CFIR to identify implementation barriers and facilitators, and NPT to explore what providers do or would do to embed the program in their current practice. Both CFIR and NPT will also be included in the ScaleUp Plan as tools to monitor and evaluate the scale-up process.
Several approaches were used to develop Health Tapestry with the end in mind. Although not done in a stepwise way, these approaches together provided important insight into Health Tapestry's spread and scalability. These approaches included developmental evaluation. This was used to do ongoing cycles of designing and testing new approaches of various pieces of the program. For example, we tried out different ways to ask about health goals. With the patient and volunteer feedback throughout these cycles of designing, testing, and tweaking, we ended up with something that worked the best for those users. Iterative, pilot, and feasibility testing. This involved testing out the intervention on a small scale to work out implementation hiccups before involving more patients or different types of patients or more implementation sites. A formal investigation of sustainability, which included a list of actionable recommendations to initiate dialogue among Health Tapestry team members when thinking about Health Tapestry in the future. This gave us an idea of what would be needed for sustainability according to those stakeholders involved in Health Tapestry. Some examples included resources or flexibility in the intervention model. An evaluation of implementation. This involved conducting focus groups and interviews with key stakeholders, including clients or patients of the program, volunteers, volunteer coordinators, interprofessional healthcare providers of the TAP huddles, clinic management, and other healthcare providers involved in the patient's care. Through this approach, we were able to listen to what people thought was working and what was not working, and also brainstorm together solutions for implementation challenges to consider in future iterations of the program. And finally, a randomized controlled trial to assess effectiveness of key outcomes, which helped to foster future buy-in for broader implementation of the program. Throughout these approaches, we ensured continuity and dialogue with provincial policymakers to ensure the awareness of Health Tapestry and the alignment with the provincial policy priorities for primary care. As a result of this, funding was obtained to assess the reproducibility of the effectiveness of Health Tapestry in 6 other sites in Ontario. We used an implementation framework called REAIM, already discussed in this module, to structure the planning and evaluation of the next scale-up phase. We also used normalization process theory as a guiding framework. This framework outlines the different kinds of work people do when implementing something new, like Health Tapestry. The trial will help us more fully understand implementation and the local contextual adaptations that can be or need to be made to ensure future scalability. At 3 of our sites, we are also testing the maintenance of the intervention, that is, seeing what happens when the research framework is removed and it runs as a program driven by the family health teams. We have learned lots about how to foster sustainability. We learned that developing an implementation guide helped us have conversations about what sites needed to think about to undertake and commit to Health Tapestry. We developed a generic governance structure, which has people representing policy, implementation, research, and volunteer organizations. We have regular meetings as a larger group, as well as smaller working groups. We continue to build meaningful relationships with stakeholder groups. This has included a strategic partnership with the Canadian Red Cross, who has volunteer organizations in communities large and small across Canada and can support the scaling of Health Tapestry. We have developed mechanisms to share learning, and this has helped build partnerships. An example is our community of practice, which includes volunteers, volunteer coordinators, and key members involved with the implementation within the family health teams to share stories of success, learnings, and brainstorm solutions to challenges across a variety of topics. We continue to learn about adaptation and how flexible the program can be to suit the local context and/or reach different patient populations.
This module discussed the process of scaling up health interventions and introduced a number of frameworks that inform that process. Having an intervention that is scalable is the cornerstone of the frameworks. As such, we need to recognize that scalable interventions don't just happen. They result from deliberate planning efforts that begin with the end in mind. Built into the planning process from the beginning are initiatives to gather information needed to design and test the intervention, assess its scalability, and secure stakeholder support. We presented 2 real-world examples to illustrate how to apply key scale-up frameworks. The Picky study was an example of how to develop a scale-up plan and use the CFR, NPT, and the World Health Organization's 12 recommendations for assessing scalability. The Tapestry study was an example of implementing and scaling up an intervention, and used REAIM to assess scale-up progress and NPT to understand contextual adaptations needed to ensure continued scalability and sustainability. The evidence base for interventions varies, so choosing the best scale-up pathway depends on the nature of the intervention, how it compares with usual practice, stakeholder support, and alignment with policy direction. Despite different pathways, there is widespread agreement that developing and testing interventions with the end, scale up, in mind is the best way to avoid the death valleys so common in our healthcare system.